Welcome everybody to the ultrasound case of this week. A bit unusual case of back pain that ultrasound really changed the management totally. This is a 68-year-old male who's known case of hypertension. He presented mainly with lower abdominal pain radiating to the back and right lower limb since 6-hour duration. He was having some history of low back pain since long time, and he was seen by neurosurgery where his pain attributed to degenerative changes of lumbar vertebra by MRI. So we thought that this time he came with his usual back pain, but a bit unusual in the history that he mentioned that his pain started suddenly and started as occipital headache radiating to the neck, then started to have pain in the upper back and lower back radiating to the right limb with tingling sensation in the leg. Then he was having lower abdominal pain radiating to the back. And we stopped at this time as we thought this is not just simple back pain and we have to think of something serious. On examination, he was really in pain. He was hypertensive. And abdominal exam shows soft and there was no tenderness. Focused neurological exam shows that he is fully conscious oriented. He's moving all the limb. There was no neurological deficit. And there was some painful flexion of the right hip. So at this time we stopped and thought we had to rule out subarachnoid hemorrhage because of the occipital headache. But head CT came normal, so the next step we really screwed up and we thought is it really possible to have aortic dissection as a cause of back pain? And the next step here is to move to the ultrasound. So we conducted focused ultrasound of the abdominal aorta. We started with transverse section just below the xiphoid process. Just for you to know the anatomy, normally we found the vertebral body with acoustic shadow and the land as a landmark. This is the abdominal aorta and to the right side is the inferior vena cava. This patient ultrasound shows again this is the vertebral body and this is the abdominal aorta. A bit unusual here, there is hyperechoic line in the middle of the lumen of the abdominal aorta. This is another view where there is again hyperechoic line in the lumen of the abdominal aorta, and this represents really the intimal flap of the dissection. Now we move to the longitudinal view of the abdominal aorta. We keep the marker of the probe toward the head of the patient and we slide the probe right and left until we found the abdominal aorta. And this is what you have to see, longitudinal axis of the abdominal aorta with its branches, and there should be no echoes inside. It is anechoic structure. The patient abdominal aorta shows hyperechoic line also in the longitudinal axis, but a bit unusual here that we could not see the whole longitudinal axis of the aorta in one view. This is another view. Again you see there is hyperechoic line in the middle of the aorta, and this really represents the dissection and intimal flap of the dissection. So at this point we kept abdominal aortic dissection really high likely. So we went back to the patient, we re-examined him again, and we found absent pulses in the right lower limb. So at this point, we immediately transferred the patient to higher center where vascular surgery available. And there they did CT angiography and shows really a bit unusual anatomy of the aorta. It was tortuous course, and that explained why we could not find the longitudinal axis of the aorta in one view. And they found the dissection started from the arc of the aorta until the abdominal aorta up to the right femoral artery, and this is the dissection in the CT. This is the dissection in the CT. Now if we correlate that finding with our ultrasound finding, we put the probe with the marker toward the right side of the patient, we'll find this is the vertebral body in the CT again, this is the aorta, and this is the inferior vena cava, and this is the intimal flap or the dissection flap. In the ultrasound, again it is confirmed in the CT. Longitudinal axis, again, you keep the marker toward the head of the patient. You see longitudinal axis of the abdominal aorta, and this is the dissection or intimal flap in the longitudinal axis. For those who don't believe in point-of-care ultrasound, or at least they believe but they are not encouraged to learn the skill, how are you going to manage this patient in the middle of the night? And how are you going to dispose this patient at 2 a.m. where there is nobody around you? Thank you very much.